Welcome to the Fertility Queen podcast. And today we're lucky enough to be joined by world renowned breast cancer surgeon, Dr. Chantel Thornton. So thanks for joining us today, Dr. Chantel, and tell us a little bit about yourself.
Thank you, Lynn, for having me. Look, I'm a specialist breast cancer surgeon. So I trained as a general surgeon and then I subspecialised in breast cancer and melanoma surgery at the Peter MacCallum Cancer Centre. I did my undergraduate training to be a doctor in University of Tasmania. So I'm originally from Tasmania, and I got a scholarship to go to the University of Hong Kong and do an honours at University of Hong Kong, and then came back and completed Bachelor of Medicine, Bachelor of Surgery with first class honours at University of Tasmania. And then I came to Melbourne to train as a surgeon. So I currently have my practice in Richmond, opposite Epworth Hospital, specialist breast cancer surgery and specialist cosmetic centre. And what I love to do is treat women that have been diagnosed with breast cancer. So I don't do any general surgery anymore, no melanoma surgery, just breast surgery all day, every day.
Wow, and how long did it take you to become a breast surgeon?
Yeah, a long time, Lynn. 17 years, so 6 years of medicine, 10 years of surgical training, and then a year of fellowship training. So 17 years, a very long time, actually, surgical training.
Lots of long hours.
Very long hours, a lot of nighttime operating, a lot of weekend on call, a lot of sleepless nights. The surgical training process is extremely grueling, although I suppose you do want it to be like that because you want to make sure that the surgeon that's operating on you has had extensive experience and feels that they've got the ability to do everything for the patient should the need arise. So it is an intensive and grueling and long training process, but it does prepare you for the real world.
Yeah, exactly. And tell us about why you became interested in becoming a breast cancer surgeon.
I've got a very strong family history of breast cancer. So 3 of my aunts, maternal cousin, and my maternal grandmother grew up knowing that she'd had a mastectomy, and I saw my favourite aunt die of breast cancer at a young age. And I just thought I can do things for women that could make a difference to their lives, particularly in terms of diagnosis and minimising the treatment that women need to receive. And also, surgery is very male-dominated, and so I thought it'd be great to be able to work with women as patients and to maximise my gender and to have almost solely female practice.
And I'm sure the patients love coming to see you, and you're so feminine. And I've heard a lot of patients' feedback is that they love coming to see you because you just brighten up their day.
Yeah, thank you. We do try to make it special. Every patient feels special and make them feel like they're a VIP and that they're getting the very best treatment. I think it's important for their cancer journey that they know that they've got people looking after them solely. And I also think it's important for their immune system because cancer is not a death sentence, particularly breast cancer. The survival rates are excellent in the order of 94%. And so many women are going to lead on to live very fruitful and long lives. And so I think it's extremely important that you treat women with respect, but also make them understand that there is hope and that this just might be a small time in their life that they need to go through in order to live a very long life.
Is family history important when we're talking about breast cancer?
Yes, it's extremely important. So I think every woman should know their family history, and sometimes it's difficult. Sometimes women are estranged from their families or they're adopted and they don't know. But if you don't know your family history on the maternal, so the mother's side, and the paternal, the father's side, then you should find out about that. About 20% of all women with breast cancer will have a significant or strong family history. Only about between 1 to 5% of those will have a genetic mutation that increases their risk. And if you've got a single relative with breast cancer, it actually doesn't significantly increase your risk because breast cancer is such a common disease. Most people will have, someone in their family, even if that's a distant relative that's had breast cancer.
So how common is breast cancer?
It's common. It's the most common cancer in women. In Australia, there will probably be about 20,000 cases of breast cancer this year, maybe more, and it's becoming much more common. So if we look at the Western world in general, it's a disease of the higher socioeconomic population, and it is probably more of a lifestyle-related disease. And so we are seeing more and more breast cancer. The rates of breast cancer actually are rocketing we're becoming better at treating it and the survival is getting better, but we are diagnosing more cases, and that's not just due to overdiagnosis, so the introduction of breast screen and finding tumours at a smaller size, but there is something in our world that is, causing breast cancer in our communities.
And what do you think that is? What sort of lifestyle factors?
Well, it's, a lot of it's not rocket science, Lynn. It's diet, exercise, alcohol, cigarette smoking. So lack of exercise, having a higher BMI, having a sedentary lifestyle, consuming, alcohol. And we used to say, no more than 2 standard drinks on no more than 4 days of the week. But now we say any alcohol increases your risk. Cigarette smoking. I mean, cigarettes increase the risk of every cancer. Women in society are having their children later. They're not breastfeeding. So I think they're really the main things, and then exposing yourself to estrogen for a prolonged period of time, so more than 5 years in say the postmenopausal lady that's having hormone replacement therapy.
A lot of my patients worry about the IVF medication and breast cancer. Is there an increased risk with IVF medication?
No, actually there's not, Lynn. Not with the modern IVF medications. I think that you give much smaller doses than they used to in the 80s. So you're sort of simulating a normal cycle. And so there's actually no evidence, there's no good data that says that IVF increases the risk of breast cancer.
And what about the oral contraceptive pill?
Yeah, again, if women are taking the oral contraceptive pill in the age group that we expect them to be in their 20s and 30s, then there is absolutely no data or evidence that shows it increases their risk. There may be a slight increase in women who are taking it in their older age, so in the sort of mid-40s. But again, there's not a lot of evidence that says the oral contraceptive pill increases your risk of breast cancer.
So what age should you start checking your breast?
Good question. I mean, I think women should be more aware of their breast from puberty. So knowing what the normal shape of the breast is, the normal contour shape, size of the breast, knowing what your normal breasts feel like. And I think that can come at any age from puberty onwards. In terms of palpating or feeling your breast every month, we don't talk a lot about that anymore. We talk more about self-breast awareness. So I would say that, women, once they develop breasts, should know exactly what their breasts feel like throughout the menstrual cycle. They should be very aware of changes in their breast. But I don't advocate necessarily feeling the breast every month on a specific day of the week. There have been many studies done around the world showing that women who feel their breasts on a specific day of the month will pick up less cancers than women who actually just are aware of what their normal breasts feel like, because we know that the breasts change specifically through the menstrual cycle. And so before ladies menstruate, the breasts get large, they often get lumpy, they get tender and painful, and that's quite normal. And then after menstruation, they go into their quiet phase. So I think ladies from a young age should be aware of their breasts, know what the changes are throughout their cycle, and then if they do have a persisting change, like a lump in the breast that's remaining after a cycle, that they see their doctor.
Mm-hmm. And what's the best investigation if you feel a lump?
Depending on your age. So if you feel a lump in your breast and you're under age 35, I would start with an ultrasound. So we always do an ultrasound of both breasts because, the breasts are bilateral, or you've got two of them, so it's good to compare them. So an ultrasound if you're under 35. If you're over 35, a mammogram with tomosynthesis, which is a 3D type mammogram, and an ultrasound. And then the take-home message from my perspective, Lynn, is that if you do have a lump in the breast, you can't be certain that that lump is a cyst, or you can't be certain that that lump is just a fat lobule. You do need to have an examination by a doctor. You do need to have an ultrasound, and then often you do need to have a biopsy. So if the lump looks like it's solid on an ultrasound, then the patient needs a biopsy, a small core biopsy, like getting your ears pierced, where we take a little tiny piece of tissue and send that off to the lab. So that's really my message to patients. If you've got a lump that's existing in your breast on ultrasound, it looks like a solid lump, then you need a biopsy. And I would also put a caveat on that. If you've got a lump in your breast that has not been seen on imaging, even if your imaging is completely clear and you've still got a lump, then you should see a doctor and you should still get the doctor to do a needle test for you.
What about women who have a first-degree relative, like a sister or a mother, that has had breast cancer?
Yeah. So a single first-degree relative doesn't significantly increase your risk. In fact, you've got to have 2 first-degree relatives on the same side of the family with a history of breast or ovarian cancer. And then you have to have one of those relatives that has had a sort of a danger sign, if you like. So they might have had a breast cancer at an early age, so less than 40 years of age. They might have had a triple negative breast cancer before 50 years of age, so that is a breast cancer that doesn't respond to estrogen or is not being fed by estrogen. You may have had a breast cancer and an ovarian cancer, or breast cancer in both breasts, or you've got to have 3 relatives on the same side of the family. And you may, if you've got a BRCA mutation in your family, so you've got someone who carries a genetic mutation, then those women obviously, who are first-degree relatives would need to be tested for a genetic mutation.
And what if you come up with BRCA gene?
Yeah, so it depends on how old you are when you're diagnosed. If you have a BRCA mutation, it does increase your risk of breast cancer in the order of up to 80%, which is extremely high throughout your lifetime. Same with ovarian cancer. The risk of ovarian cancer is in the order of up to 60%, can be higher. So we do recommend that ladies that have a BRCA mutation, if they're in their younger childbearing years, that they do get annual imaging with an MRI, and an MRI is currently funded by Medicare for women that have a BRCA mutation, that they have regular imaging of their breast, and that they consider having a mastectomy, so a bilateral mastectomy where we take away the breast tissue throughout both breasts, leave behind the entire skin envelope, and then put in an implant or make a new breast for the lady. And then usually when they're in their 40s, we would take out their ovaries and their tubes to reduce the risk of them getting an ovarian cancer or a cancer of the fallopian tubes. And that's probably where you would come into play there, Lynn, as well. If we did have someone who was thinking, determine that they did have a BRCA mutation, that they do need to think a little bit more about family planning. Are they going to breastfeed their babies? If not, you can still, have a mastectomy and a reconstruction and have a baby quite easily without needing to breastfeed. Obviously, we know breastfeeding is important, but it's still okay if you haven't had babies and you've had to have your breasts removed. You can still quite easily deliver a baby, but also being aware that, the clock is ticking a little bit and that they do need to think a little bit more about their fertility.
And we've had some patients that have been pregnant diagnosed with breast cancer. What about, do they need to end the pregnancy?
No, not necessarily. It's a very tricky time. Obviously, it's very emotionally difficult. But, you can treat women quite easily who are pregnant, and women can have chemotherapy if they are pregnant. We don't like to operate in the first trimester because there is a increased risk of miscarriage or spontaneous abortion, we call it in medical terms, of the fetus. But if we have to, we will do surgery in pregnancy. Often we are giving what we call neoadjuvant chemotherapy, so we're giving the chemotherapy first and then operating second. The only thing we don't like to do in pregnancy, and we usually don't do, is radiotherapy. So radiotherapy can't be given, but usually the period of time, by the time the patient has the surgery and the chemotherapy, 9 months is sort of over, and so the patient has already delivered the baby. Some of my patients used to say, I'm going to get very angry if my baby doesn't come out with any hair after I've had chemotherapy, but the baby will come out with hair, don't worry, and the baby will be safe if a patient's having chemotherapy while they're pregnant.
What about hair loss during chemotherapy? I know that you can cool the scalp. Does that actually work?
Yes. Look, it has mixed results, Lynn, and it does. With your beautiful hair, Lynn, hopefully you never need it, but it would probably be okay because you've got beautiful thick hair, strong thick hair. It does depend on the colour of your hair as well, and the condition of your hair pre-chemotherapy. And so women that start with very thick hair usually do better than those that don't. It's not 100% foolproof, but women can usually keep a reasonable amount of hair, particularly in the frontal region where they can wear a little bandana or something like that visually it looks like they're maintaining their hair. Some women will keep the whole head and they will work throughout the whole time they're having chemotherapy and no one will know. And some women will lose almost everything. So it really does depend on your hair type and how you look after it. Also on the application of the scalp cooler. We've found that giving sedatives under the tongue help during the chemo process to try and relax the patient because it can be quite uncomfortable.
Yeah.
It's almost like the ice cream cone headache that you get when you lick on a cold ice cream or icy pole. You get that head freeze and it can be uncomfortable. So what I say to ladies is give it a go. It works for some people, but not everyone. And some hair is better than no hair. We encourage ladies to cut their hair shorter as well before they start and use great conditioning treatments and things on their hair as well.
And what about the future of breast cancer treatment? Where is that heading?
Well, I might be out of a job, Lynn, and I might be coming to ask if I can do some work with you. That'd be great, wouldn't it? I'd have to learn how to do embryo transfers or get my laparoscopic skills back. But no, look, I think what will become of breast cancer, hopefully, is that we will be finding medications to treat breast cancers, and so we'll be doing less and less surgery and more minimally invasive surgery. I think the other thing is we will be diagnosing more pre-cancerous change, and we'll be diagnosing more cancers that we will be able to determine do not need surgery. So, for example, in older ladies, we'll diagnose a breast cancer that might be a low-grade problem, and we'll be able to say by looking at the genetic makeup of that tumour, this cancer will not go on to cause this lady any troubles. This cancer can be left in situ and it can be monitored. So I suppose, surgeons may be redundant, in 10 or 15 years' time. Certainly, as the junior surgery community come through, they're doing a lot less intensive surgery. So because we're not being presented with large fungating tumours, we're not being presented with large axillary or armpit lymph nodes involved. And so some surgical trainees that are training now probably have never done, a very nasty axillary dissection where the whole armpit is full of cancer, because thankfully we're finding cancers at very small sizes. And the medication that we have now is killing the tumour cells, such that when we give patients what we call neoadjuvant chemotherapy, where we give them chemotherapy first, we're then taking the patient to theatre. We're putting a little clip in the tumour at the time of diagnosis, taking them to theatre 6 or so months after they've completed their full chemotherapy regime, and we're finding absolutely nothing. So the patient has what we call a complete pathological response. And so, the thinking patient saying to me now, well, Chantel, do I need any surgery at all? And currently we're still advising, yes, remove that little clip and have a look at the tumour bed, make sure there's nothing left behind. But I think the future will be that we will be able to say to patients, no, you don't need any further surgery. You are clear of this disease. We're just going to monitor you every year. And we're looking more at cancer now as a chronic disease, Lynn, and so more people die in Australia of heart disease than they do of cancer.
Yep.
And so what we're saying to patients is that a diagnosis of cancer is not a death sentence.
Yep.
It is something you may have to live with chronically for the rest of your life, but you're still going to be able to live a good, long life and be able to enjoy your life, just as if I told you, oh, I'm sorry, you've got diabetes, you've got heart disease, you've got rheumatoid arthritis. Those patients are living with a chronic disease, but many of those people are living very full and active lives. And the same as what they will do if you are diagnosed with metastatic cancer, or if you're diagnosed with breast cancer, you can still live a very active life, and we'll just give medications to keep that cancer at bay.
So for a woman that's discovered she's got a lump, what does she do?
Yeah, good question, Lynn. Well, most people have a really good general practitioner, and so you could go and see your general practitioner. You could get an ultrasound and a mammogram if you're over 35, or ultrasound only if you're under 35, because we don't want ladies in their 30s to be exposed to too much radiation, which is associated with mammogram. And then go back and see your GP and get an examination with your GP. If that GP deems that you need a biopsy, or the imaging, as in the ultrasound or mammogram, you can see something abnormal on that, then you will often be referred to a breast surgeon at that time. And so you'll go and see a breast cancer surgeon, and the surgeon will do the same. They'll review the imaging, and then they'll feel the breast and look at the lump or the problem that you've got. And then, if able to, in the consulting rooms, I will do the biopsy myself using a small needle, sort of like when you get your ears pierced, it's a little gun, makes a clicking noise, and we use a little bit of local anaesthetic, and we just get a bit of tissue, small microscopic sort of tissue, which goes in a tiny formalin pot, and off it goes to the pathologist, and it gets assessed to see whether or not that is anything nasty. Usually we get this returned within 24 to 48 hours, the results, so the lady doesn't have to wait too long, because the waiting game is psychologically very demanding on a patient and can be very distressing. So once we meet back with the patient, then we give the diagnosis. And if it is breast cancer, we usually have a plan for the patient. So if it's a small operable cancer, most patients will be opting for breast conservation surgery, whereby we take out the lump with a margin of surrounding tissue and sample a couple of lymph nodes underneath the armpit. Some women, unfortunately, will have broader areas of cancer, or they may have multifocal cancer, or they may elect actually to have a mastectomy. In that setting, we'd also sample the lymph nodes under the armpit, and we would do one of two things: a mastectomy, a skin-sparing mastectomy, where we keep the entire skin envelope and make the patient a new breast, or if they're not wanting to get a breast reconstruction, and sometimes that's women in their latter years, not to be ageist, but some women in their latter years will be saying to me, well, I've done what I need to do with my breasts. I don't need to breastfeed anymore. I'm not defined by them by sexuality or femininity. I'm okay to have a simple mastectomy. We just have a simple mastectomy. In my practice, I do very few simple mastectomies. I've got to be honest, even ladies that are in the older age group will often elect to have a mastectomy with a reconstruction. And certainly that is good for maintaining their femininity and sexuality. Once a final pathology comes back, regardless of the type of surgery you have, your case is discussed in a multidisciplinary team meeting. The multidisciplinary team meeting is a meeting whereby all of the professionals that are treating the breast cancer, so the breast cancer surgeon, the oncologist, the radiation oncologist, medical oncologist, the radiologist, the pathologist, the nurses, they all come together and we discuss the case. And we know that ladies that have their cases are discussed in a multidisciplinary meeting will have a higher survival rate than those that are not. So I think if you've got a diagnosis of breast cancer, you need to ask your surgeon, is my case going to be discussed and what is the outcome of that discussion? We look at the pathology under the microscope and then we canvass the professionals in the room. We say, this lady is so many years of age, she's got so many size cancer, what grade it is, what size it is, how many nodes are involved, as in either cancer in the lymph nodes or not. And then we come to a decision, what extra treatment might the patient need? So the patient after surgical intervention will often require chemotherapy, particularly if they're young or particularly if they have a hormone-negative breast cancer or a HER2-positive breast cancer. They'll then go forward for their chemotherapy, which usually runs over 4 to 6 months. And then after the chemotherapy is completed, women that keep their breast, have breast conservation, will have some radiotherapy. And women that have an estrogen, a tumour driven by estrogen, will be offered a tablet therapy to take once a day for between 5 to 10 years. Women that have more advanced breast cancers or might present with HER2-positive breast cancers or triple-negative breast cancers, they will sometimes be offered chemotherapy first. So we'll reverse the way we do the treatment. So we'll give the chemo first and then we'll come back and do the surgery and the radiation afterwards. So there's sort of many ways of looking at the treatment protocols. What I would say to you is, and I always am quite amazed by this, Lynn, is that people fear losing their hair and having chemotherapy more than they fear the surgery, actually. And as a surgeon, that always amazes me.
Yeah.
And I guess it's probably because surgery is more definite.
Yes.
You know, they're in hospital for a couple of days, the procedure's done, the cancer's out, it's finished. Where chemotherapy is prolonged, you know, it's week after week after week. And most women don't realise that, you know, they are often able to lead very normal and active lives during chemotherapy. And chemotherapy, I think, has been given a bad rap in the past. In the lay community, people think that, you know, chemotherapy kills people, you know, and they get very worried about the side effects and they really say, I don't mind if I lose my breast, Chantel, but please, I don't want chemotherapy. What I would say is that, you know, I can treat breast cancer in the breast, and even though I'm a surgeon and I think, you know, surgeons are fabulous and we say we love to cure cancer, actually the medication's what cures cancer.
Yeah.
I mean, breast cancer is a systemic disease, Lynn. It's, you know, one little cell rotating and circulating around the body through the bloodstream. People don't die of breast cancer in the breast. They die of breast cancer in the liver, in the lungs. And so my surgery will stop it from going elsewhere. But if one little cell has dropped down and circulating around the body, the drugs are what's going to kill it. So I'd say to patients, keep an open mind, follow the instructions of your team, which is your multidisciplinary team, and don't be fearful. It is scary, but, you know, most people tolerate the treatment extremely well and can live very full and active lives.
And do most people require chemotherapy?
Most ladies that are young, and so my patient demographic is young, will require chemotherapy. So regardless of their grade of tumour, their size of tumour, or the fact that it's node negative, I'd say that most ladies that are under 35, or even I'd go so far as to say under 40, would need to prepare themselves that they will be offered chemotherapy. Because those women, we want them to live to their 86, so that's 50 more years for breast cancer to come back. So you need to hit it hard. Hit it hard in the beginning. Take all the treatment that you give in early to prevent that cancer coming back, because we know breast cancer is a disease that can come back many years later. And so we often talk a lot about your immune system, staying healthy, staying happy, exercising, keeping your body in a sensible BMI or body mass index, because we know the immune system impacts heavily on the way people's bodies interact with cancer cells. And this is really looking from a research perspective at the moment, and there'll be a lot more in the next 10 years that will know your immune system is modulating the way you attack that cancer. And so if you can stay very healthy and active and happy, then you are going to be helping with the treatment of your breast cancer.
Very interesting. And what about breast augmentation or breast implants and cancer? Do breast implants increase the risk of cancer?
Yeah, good question, Lynn. There's been a lot about that in the press recently. Anaplastic large cell lymphoma is a specific type of lymphoma or cancer that has been associated with some type of breast implants. And so it would be important to ladies to know which type of implants that they have. Are they textured implants or are they smooth implants? What brand they were. And the patient's plastic surgeon can help them with that information. It is a very rare diagnosis and it usually is associated with symptoms. So women will come, the implants may have changed shape or position, they may be uncomfortable, they may have a lot of fluid around their implants. And so what we do recommend is that women that have implants do go for annual imaging. And some women are opting to have an MRI as well with implants because you do get a better picture of the breast. You get a beautiful photograph of the breast and the implants, looking at the capsule and making sure the capsule's not ruptured, looking for thickening of the capsule, looking for fluid, some of the signs that might tell you that their patient has this very unusual cancer called anaplastic large cell lymphoma. Breast cancer per se is not increased with implants. And in fact, we find that many ladies have implants and are more able to find a breast cancer because if they've got small breast tissue and they've got an implant sitting behind their breast is being pushed out, and so they can actually feel the implant more easily. There have been some research that looked at the fact that breast cancer has been more commonly found in women having implants, and that's probably more because patients were going for imaging.
Right.
So when they've been to a plastic surgeon, the plastic surgeon's been very proactive, and I think all plastic surgeons should. They should ask their patients to have breast imaging at baseline before they have any breast surgery. Mm-hmm. And they're finding, breast cancer. So in a way, the breast implant or the procedure to go forward and have the implants probably saved their life. And women that have got implants are probably having more active surveillance than women that aren't.
Regardless of their age?
Regardless of their age.
Yep.
Yeah.
So if you were 30 considering
if you were 30 considering breast implants, I would probably just do an ultrasound of the lady's breasts. And I think it's not, it's not an invasive thing to do. It's good to have an ultrasound at baseline, particularly if the lady does have a little cyst in the breast, because once you put the implant in, you'll be able to feel that cyst. Yep. And then the patient will think, oh my goodness, I've got something in the breast. But if they knew about that cyst before, they could have treated that before.
And a lot of my patients complain of cystic breasts. When is it a time to worry? And I know I've sent you some patients over the years as well because you do an ultrasound, there's lots of little breast cysts throughout the breast. So when should you worry about a breast cyst?
Cysts are very common, Lynn. They're very normal throughout the menstrual cycle. In fact, fibrocystic change, we used to call it fibrocystic disease, and then people would ring up and say, doctor, I've got a disease. And then it's been the terminology has been changed to fibrocystic change because it is very common. And it is particularly more common, before you menstruate and also while you're on IVF medication. So cysts do not increase your risk of breast cancer, but what you need to know is if you've got a lump in your breast and you've had cysts before, you can't assume it's a cyst because the only thing that can tell you is a cyst is the ultrasound. Yep. And so you've got to put that ultrasound on the breast to see, is there just fluid in that? Is that a normal, simple cyst that does not need any attention? If the cyst is large or it's palpable and the patient can feel it and it's tender, we usually recommend just aspirating it because they can be uncomfortable and they can hide lumps sitting behind them. Some women will have cysts that are 4 or 5 centimetres and they're huge and they won't be able to feel them. They'll have no pain. Other ladies will come into me and they'll say, Chantel, I know there's something there. We'll do an ultrasound. There'll be a 3 millimetre cyst. Wow. But we'll aspirate that cyst and they'll say the pain's gone. So, you never know what you're going to find. If the ultrasound shows that the cyst has a thickened wall, it has sort of septations or walls within it, it has a solid component to it, it's very complex or complicated, then we would say you need to get active management for it and you need to get follow-up for it.
What about fibroids in your breasts?
Yeah, fibroadenomas, they're very common. Again, they don't increase your risk of breast cancer. However, you can get breast cancer anywhere in the breast, including in a fibroadenoma, because fibroadenomas are an overgrowth of normal breast tissue. And so, having the fibroadenoma there will not cause the breast cancer, but because it is made up of breast tissue, you can get it in that site. Some ladies will have multiple fibroadenomas. They might have 15, 16 per breast. It can be very difficult to work these ladies up because, the older they are, and if they're continuing to get fibroadenomas in an older age group, they've got to be biopsied. You've got to prove that's a fibroadenoma if they've got a solid component, and that they are solid lumps, fibroadenomas. So we would usually biopsy the largest fibroadenoma or the one that looks the most atypical. In saying that, there is some fibroadenomas or some lesions within the family of fibroadenomas called Phyllodes tumours. And Phyllodes tumours can be a worry. They can be malignant, but they're not a breast cancer. They're a totally different type of cancer, more in the family of sarcomas actually. And those tumours do need to be removed. They need to be removed with a wide margin. And they sometimes also need to have radiotherapy. And so some ladies that have fibroadenomas that look atypical need to be managed under the care of a breast surgeon to make sure that they're not missing a Phyllodes tumour.
Well, thank you, Dr. Chantel, for joining us today on the Fertility Queen podcast. Is there anything you'd like to add or tell women about breast cancer?
Yes, Lynn, I'd like to say if you've got a breast symptom, so you've got a lump in the breast, a change in contour, shape, size of the breast, nipple discharge, a change in the skin over the nipple, that you see your doctor. Make sure that you see your doctor, don't delay, don't be worried about seeing the doctor. It'll just be a routine examination and you'll get some simple breast imaging. Don't be scared to see your doctor if you've got a breast symptom.
Thank you very much, Dr. Chantel. It's been great having you today.
Thank you.
Thank you.